It was a fantastic ASH this year at Atlanta. We were very fortunate, or I was very fortunate to be able to attend in person, which was really great to see so many collaborators and so many exciting abstracts. I think that one of the studies that really caught the imagination was the iStopMM presentations. iStopMM, of course, is led by Professor Sigurdur Kristinsson, and he gave an abstract on Saturday, which was looking for screening of monoclonal gammopathy of undetermined significance, a population-based randomized clinical trial with the first results. Tremendously exciting to see that. And this was really followed up by looking at how COVID had affected MGUS patients, the importance of the correct renal reference ranges in patients, as well as the prevalence of smoldering multiple myeloma, which with the iStop study has been shown to be 0.5% of the population against a previously expected prevalence of around about 0.02% of the population. So for the first time, iStop is really starting to open our eyes as to what the true community prevalence of some of these disorders is, or some of these disorders are. The binding site has been involved with the iStop study since its first inception. In actual fact, we were I was talking to Sigurdur just at ASH about the early conversations we had at the Edinburgh Freelike chain meeting back in April 2015, and how important it was going to be to do a screening study for MGUS, and some of the challenges that we would face with screening an entire population. Iceland as a population are phenomenally willing and accepting of these large clinical studies. And so as we were talking, Professor Kristinsson was very, very clear that he felt that Iceland was the right place to do this study, and that he thinks that of an addressable population of somewhere in the region of 140,000 people over the age of 40 years old, then we should expect to get around 80,000 people consenting to our study. And he was almost bang on the money, really, with a little over 75,000 people providing serum samples. You can imagine 75,000 serum samples that needed to be screened with the serum free light chain test, Freelike, electrophoresis, and then following the IMWG guidelines, a positive for either Freelike or electrophoresis was reflex to immunofixation. And then we ran IgG, IgA, and IgM on the Optite analyzer, has some quite large logistical issues. Not least the fact that we wanted to return the samples in good time, which meant we were receiving somewhere in the region of 400 samples per day, and analyzing them, validating the results, and then returning them back to Professor Kristinsson within a month's period of time. We started our collection of samples on the 26th of November 2016, and we closed the last sample in January of this year. And during that period of time, I don't think there was a week went by where we weren't analyzing samples. The binding site had 8 people working on this project, and we had perfected a way of the samples arriving in in a frozen state, defrosting them, analyzing them, and then returning them to the freezer, and then shipping them back. So a tremendously complicated process, but one that we ended up doing remarkably efficiently. What we're really excited about is that the next set of studies with the iStop data will be using our mass spectrometry technology, which we have called EXENT. So the mass spectrometry technology, which was built on innovative work from the Mayo Clinic, where we use immunoprecipitation pull-down beads for IgG, IgA, IgM total kappa and total lambda before visualizing the result of that precipitation on a MALDI mass spectrometer following reduction of the patient's immunoglobulins. Whilst the iStop study had 6 abstracts this year, 4 oral presentations, we were extremely excited to see that EXENT had 3 abstracts submitted this year, and all of those abstracts were chosen as oral presentations. The first abstract, which was presented, came from collaborations with Dana Farber and Irene Gabriel and was presented by Habib El Khoury, and they had used EXENT to screen the PROMISE population with mass spectrometry. What they found is, using traditional techniques, there was a low incidence of MGUS, somewhere in the region of 5% or so, but with the mass spectrometry, this increased to somewhere in the region of 10%. So we can see that the implementation of mass spectrometry at the very earliest part of the patient journey is going to identify MGUS at the earliest possible stage. And so that was a tremendously exciting abstract to see. We then saw Dr. Naomi Pugh from Salamanca and from the GEM group show how mass spectrometry can be implemented during the patient journey to monitor patients as an alternative to electrophoresis and to immunofixation. I think one of the exciting things about Naomi's work was that whilst post-consolidation, immunofixation and electrophoresis offered no discrimination between the 2 populations, either positive or negative, both Nextgen flow cytometry and mass spectrometry clearly separated the population, so gave very much clinically relevant data. The Nextgen flow cytometry and Nextgen and mass spectrometry were broadly equivalent, and there was a very high negative predictive value by the mass spectrometry for the prediction of the Nextgen flow cytometry results. And actually, this negative predictive value was slightly improved upon with the addition of the samples being evaluated by LCMS rather than MALDI. And so we can see that we've had the scenario where early use of the EXENT system identified MGUS to a greater sensitivity than traditional methodologies. We can monitor the patients using the mass spectrometry systems throughout their journey to a much greater sensitivity than using traditional methodologies. And we can start to think about, realistically, a serum-based MRD assessment. That whole idea of serum-based MRD was really exemplified by Dr. Hannah Giles, who utilized free light chain antibodies bound to paramagnetic beads in a very analogous way to the GAM kappa and lambda assays. So she coined this Freelike MALDI-TOF mass spectrometry. Using Freelike MALDI-TOF mass spectrometry, she was able to have a greater sensitivity for the detection of residual monoclonal free light chains than immunoturbidimetric methods. This means that as the free light chain ratio became normal, we were still able to identify monoclonal peaks. And sometimes we're able to identify monoclonal peaks even when there was very, very small peaks present indeed. The presence of these peaks, even in patients who achieved a complete response, was associated with reduced progression-free survival. And this means the greater sensitivity of Freelike mass spectrometry, Freelike MALDI-TOF mass spectrometry, gave clinically informative information in the study group. We also saw that the Freelike MALDI-TOF provided prognostic information in patients who are MRD negative at 6 months post-maintenance randomization. And so there was a tremendous excitement about the possibility that mass spectrometry could reduce the bone marrow burden on patients. Overall, I think that this year's ASH showed that increasingly we are aware of the importance of identifying MGUS and some of the challenges that may face, the importance of identifying smoldering multiple myeloma, who are perhaps present in far greater numbers than we originally thought. And of course, that's an important group for us to consider, because smoldering multiple myeloma is one of the disease areas which is a keen focus of interest in and around clinical studies. And once identifying these patients, using the most sensitive technologies for monitoring the patients clearly gives value, either in the traditional sense, looking at intact immunoglobulins as presented by Naomi Pugh, or the very exciting opportunity of having Freelike on mass spectrometry. How was that, Inara?
That's very good. But I did forget to mention in the beginning, if you can introduce yourself. I was like, darn it.
Oh, okay.
Yeah, we'll edit it. Don't worry. We'll have a good editing at the beginning.
I can introduce myself now if that helps.
Yeah, perfect.
Okay. Good morning, good afternoon, or good evening. My name is Stephen Harding. I'm the Chief Scientific Officer at the Binding Site. I'm tremendously excited to be at ASH in Atlanta this year, and looking forward to seeing the presentations by the iStop team, the PROMISE team, the Spanish myeloma team, and the MRC team. The latter three are looking at mass spectrometry in MGUS through to multiple myeloma.